What up, all you badass motherfuckers? Welcome to class. Are you ready to learn to save the world? Alright, so thanks for being patient during your quarantining. I'm hoping this, how I have it set up, is beneficial for you guys. I haven't quite looked at your how can I help you assignments yet, but I will get there, I promise. Today, a few other just housekeeping things before we get into the lecture. How it'll pay out, so watch this video and then respond to the questions linked with the video. In this particular one, I will put a bonus question because I feel like we need a bonus question. Class is very formally coming to you today from the hammock my brother set up in our basement with my dog and my Dr. Pepper. Alright, let's get started. Pulmonary pathology and ventilator management. These are the pages for Lindsay Jones and... oh crap, I think those might be the waveform pages. Let me double check, and I'll let you guys know. There we go. Vent sessions. So I wrote this before all the adventures started happening amongst us, and I was hoping to talk about clinical, different pathologies you guys might have heard about, seen, things that might have been a little bit different, but I'm now going to include the vent session in along with the assignment so that we're not double dipping. I kind of see it as redundant to do both the vent session and the assignment. I will make sure to respond to you if you guys have questions. If there's something you want to talk about, we can even talk about, when we get to the ARDS, I will address our COVID-19 life that I'm pretty sure is on the front of all of our minds. So even though I'm still learning, I'll tell you what I do know and how we can respond, having it being our time to shine as respiratory therapists during this scary pandemic. I'm going to separate this lecture into two different sections. We're going to have pathologies that directly affect the lungs and the pulmonary tissue, and ones that indirectly affect the lungs and the pulmonary tissue. The ones that directly includes acute lung injury and ARDS, obstructive pulmonary disorders, pulmonary edema, pneumonia, and burns and inhalation injury. And that one's a little bit of a bridge because it will indirectly affect the lungs, which moves over to major surgeries, traumas, neurological conditions, vascular shunting, and then pneumo and hemothoraxes and pleural effusions. This is just a small handful. I'm sure when you're in clinical and you're working and you're doing real life, you're going to see so much more than this. This is just kind of a small handful of what you will frequently see. Acute lung injury, not me, is the beginning of the transition stage into ARDS. So kind of think of it as the step before we go into full-blown ARDS. It is a result from injury to the lungs, trauma, aspiration, inhalation of foreign gases or material. I like to think of it as the bruise or the hit before we go into ARDS. I know in previous lectures we're going to dive really deep into ARDS, but with acute lung injury, I like to think of it as the initial hit the lungs take that hurt and cause damage before we have the secondary effect of ARDS. So, any of you that have siblings, I'm bringing another sibling analogy in. Have you ever been like roughhousing or playing with your sibling or whatever when you were a kid, and then you get hit, and that initial ouch? Think of this as that initial ouch to the lungs before it begins to swell and heal and ooze, or cut, or whatever you want to use. How you catch it is, it's the very beginning where you're starting to decrease pulmonary compliance. So both your peak and plateaus are beginning to increase. Change in permeability of alveolar membrane. Basically, that's just the fancy wording for we're having to have increased ventilatory and oxygenation. This is, you'll notice this on a patient when you're like, okay, I know we were currently in a trauma, or this patient aspirated, something happened to the feeding tube, whatever the situation may be. And all of a sudden, I was on these settings, we were comfortable. Now our CO2s are beginning to climb, and my oxygenation's going up. What's going on? And also my peak pressures are starting to go up, my plateau. It's the very, very beginning start of ARDS. ARDS, adult or acute respiratory distress syndrome. This is our bread and butter as respiratory therapists. The fancy wording for what's going on is non-cardiogenic pulmonary edema due to leaky pulmonary capillary membranes, which is just a mouthful for the heart is not involved, and there is fluid inside the alveoli due to damage, and the little capillaries that surround each alveoli are beginning to leak fluid into the alveoli. This results from direct or indirect pulmonary injury, primarily the flu, aspiration, near drowning, pulmonary contusion, smoke inhalation, trauma. And again, back to our analogy of when you get hit or cut, this is when externally when your heart begins to swell and ooze. That's what's happening in the lungs. Some of the identifying features are peak and plateau pressure, because remember, our peak pressure is fix that shit only, and then a rise in both peak and plateau pressures are the oh shit, I need to respond. So you're going to have compliance issues, refractory hypoxemia, and a drastic decrease in pulmonary compliance. So we haven't talked much about surfactant, because that's primarily more of an issue in the neopeds world, but ARDS affects surfactant in the lungs, which is produced from the alpha cells in the alveoli, and it basically, the pulmonary edema comes in and washes it all away. Think of it as it washes it all away. Surfactant is, I like to call it lung soap. It's a slippery substance inside the alveoli that causes those alveoli to slip past each other. So think of it as your lung soap, because it's causing it to be slippery in there. And that's what decreases pulmonary damage, is the fact that those alveoli aren't sticking together. This is what causes the damage in ARDS, is that edema comes in, it alters or washes out that surfactant, and causing those alveoli to stick together, leading to issues with pulmonary damage and complications with oxygenation. I'm sure you're all wondering about COVID-19, since that is a subject that's on everybody's mind right now with being quarantined and what's going on as respiratory therapists. I've heard both, that they're thinking it's airborne and droplet precautions. We're just treating it like airborne just to be safe and, go above and beyond to protect beyond, have regrets later. This ARDS ventilation is how you will ventilate a COVID-19 patient that might need to be intubated. I think the current standard is they're going to have it be the patient can be supported non-intubated up to 6 liters nasal cannula, and then rapid sequence intubation. So push meds, don't even bag, hurry and get the tube in. And this is primarily to prevent the spread of the infection. While there's a lot of patients that might do well on BiPAP or high flow, some of the doctors lately have been using just direct intubation in order to protect staff and protect the spread of COVID-19. That's one of the theories behind the intubation process. Flu, normal just flu, influenza A and B, that's what the majority of the patients in ARDS I've had to ventilate. And you would ventilate it very, very, very similarly. And ARDS-net protocol, it's this international study that went down where they did hundreds of thousands of tests internationally to see what works best. And what they're finding is the best strategy for ventilating ARDS is to do high PEEP, high rate, and a low tidal volume. And that is about 4 to 6 mils per kilogram on your tidal volume. And you want to maintain a higher mean airway pressure and a lower peak pressure. One of the things, so a lot of you will be like, so would I even set this up? If I know I have a patient that is either a crashing influenza or I haven't taken care of any COVID-19s yet that I'm aware of because I'm primarily in newborn ICU, so they've been putting me with patients that can't be near infectious disease RTs. So I've been taking care of a lot of the like lung transplants that are still intubated and that kind of stuff because they're trying to staff us where some of us are with immunocompromised patients such as transplants and newborns, and others are directly with the COVID-19 patients. And I lucked out to be on the immunocompromised team. Anyway, but back to ARDS ventilation and how you would set up the ventilator is I would initially start in volume control because that's ARDS protocol. Even though I love pressure control, a lot of doctors, if we know we are in ARDS, we go to volume control. I would set up my tidal volume somewhere between 4 to 6 mils per kilogram. I might go 5 just because it's the middle. A predicted or ideal body weight. I would put my PEEP, I would start at a therapeutic PEEP of 10. You might even have to go up. These patients can get pretty sick, especially with oxygenation in their reserve. And then I would just adjust my respiratory rate to match an appropriate minute ventilation of around 9 or 10 because this patient should have a little bit higher CO2 because they will be in a respiratory failure. Along with that, you'll have a little bit higher rate typically, maybe like mid to high 20s, even low 30s. And then you allow for some permissive hypercapnia. And we're not talking like 60 CO2. So permissive hypercapnia is we're allowing higher CO2 levels. If I had a higher CO2, I would do more of like around 50 range. I would be like, when we are alive, we are ventilating, we're doing okay. So back to COVID-19 and flu and ARDS ventilation. A lot of the diagnosis comes for ARDS from the chest x-ray. You'll hear it say there's honeycomb pattern, there's ground glass appearance. Anything like that will be one of the indications that we are in ARDS, along with clinical symptoms that they're showing, such as decreased compliance. Think of it as basically our lungs are turning to rocks. We're trying to ventilate against a wall instead of a very flexible substance we're going through. That's why we do the PEEP, because back to the surfactant, we don't want those alveoli to stick together and rip back apart. Remember our seal clapping we did in class? That's what's happening, is we are trying to prevent those alveoli from coming together, and that's the theory behind the higher PEEP. Again, just to address, mostly what we've seen is they're finding it is older people with comorbidities such as history of smoking, a COPD, anything like that is primarily what's causing the biggest issue. Trying to think what else I want to tell you about ARDS. It's very, very common. A few of you, we will get into this. You'll learn more about this in adult critical care. There is another vent setting that called APRV or bilevel, where it's like pressure control staying on its head. And it's good if you're going into ARDS. You want to try to put them on that before they're in full-blown ARDS. Another mode that I absolutely love if I'm ventilating an ARDS patient is VC+. Let's talk about VC+ for a minute, because I know we touched on it, but it can be a little bit funny when you're first learning mechanical ventilation. You will initially set the patient up in volume control, but you set an I time, which feels a little wonky because that's what you set in pressure control. In the alarms, you set a peak pressure pop-off, which is once we reach this peak pressure, we're going to drop the breath so that we can prevent pulmonary damage due to high peak pressures. Another thing on VC Plus that is specific is the patient can control the flow they are receiving on inhalation. So between being able to control peak pressures, the patient getting the flow they want, and then volume control, which is under the typical ARDS ventilation strategy. Between all of that, I love VC Plus for ARDS patients. That's respiratory according to Atlee. Anyways, I think you guys are sick of that. Oh, here we are. Lung protective strategy. You'll also hear it called lung protective strategies. So, high PEEP, high rate, low tidal volume. You remember those three things. If there's anything else you remember, it's high PEEP, high rate, low tidal volume with acute lung injury and ARDS. So 4 to 6 mils per kilogram. Utilize PEEP for oxygenation. You also will have higher FiO2s typically. Allow for permissive hypercapnia. That's our around a little bit higher, around higher 40s, maybe low 50s, even if they're insanely sick. What sucks the most is you just have to support the symptoms. It's happened. You just have to help support the patient through it. You can give some diuretics. Sedation is huge because that will decrease their oxygen usage. But mostly it's ventilatory support. So other treatments, the patient might be placed on ECMO, extracorporeal membrane oxygenation. That's basically we're doing all the work for them on this fancy machine. Sedation and paralytics. I have had lots of ARDS patients paralyzed. Diuretics to kind of help get that fluid off and out of the lungs. Prone positioning. Some of you may or may not have done prone positioning. The theory there is to flip the patient and allow the alveoli that have been in the posterior part of the lung to reinflate, and then also have the blood flow that's been in the back come to the front with those already inflated alveoli. And then mostly it's ventilator management. So go us. This is all on you. This is why you are a fully functioning and smart respiratory therapist. Okay. Obstructive disorders. It is alteration or destruction of pulmonary tissue that prevents or decreases exhalation process of ventilation. There are 5 different types of obstructive disorders, and what it is pulmonary damage, decreasing exhalation. But what helps categorize them is either where or what causes it. So asthma, this is genetic. This is, you can't prevent it, but you can maintain and control it. Emphysema is either environmental or choice-based. It's totally this one's preventable. Same with chronic bronchitis and bronchiectasis. Cystic fibrosis, just like asthma, is genetic, and I'm just sorry that biology's a bitch, and that's how it happens. With asthma, It's primarily in the main airways, and it's bronchoconstriction and inflammation in the main airways, causing difficulty to breathe. I know all of you probably have dealt with an asthmatic. The best treatment is prevention with asthma, but if not, they respond very well to albuterol. If you have a patient in a complete asthmatic crisis, they might need IV steroids with a shit ton of albuterol. They might need to be intubated or on BiPAP in order to do well. Emphysema, chronic bronchitis, and bronchiectasis, these are all pulmonary damage due to either environmental or choices. I have a grandpa with COPD that has never smoked a day in his life, but he worked in a mill all of his life. Emphysema is at the very terminal airways, so where the alveoli are. The best description I can give of how emphysema looks is all that just crud that comes into the lungs causes the alveoli to stick together and cause damage and turn into either a cylindrical or different shaped alveoli. So the visual I like to put is our normal healthy alveoli are little tiny water balloons that open and close, and they keep their shape and return to normal. Where emphysema, we basically just have these big saggy condom alveoli going on that make it hard to return to that shape. They don't ever return that shape, but that's where air trapping happens. Chronic bronchitis is chronic inflammation in the upper airway, in the two main bronchi, inflammation of the two main bronchi that is categorized if it happens 3 consecutive months for 2 consecutive years. And then bronchiectasis is in the kind of middle airways, is the damage and constricture in the middle airways. Cystic fibrosis is mostly a mucus and secretion issue, where these patients don't break down the mucus in order to get it up and out, and that's what causes the damage there. So then comes to the question, if I do have a patient with an obstructive disorder, how do I ventilate? Allow for exhalation. Exhalation and pressure are your two best friends. So you might do a little bit lower respiratory rate with a shorter I time or a faster flow to allow for longer exhalation. This is because we have air trapping in the lungs, which makes it harder to exhale. Pressure is your best friend. If I can tell you anything with an obstructive disorder, BiPAP is your main bitch. BiPAP is going to save lives. I am just going to preach that your V60 is your best friend if we are having an obstructive exacerbation. Before you grab anything else, grab a BiPAP. You can give medications through your BiPAP. Just make sure your spring T is after your whisper valve so that the patient gets the medication instead of the whole room. And that helps move that medication into the lungs, and also they just respond so much better. Inline bronchodilators or SVNs or bands, such as albuterol or duoneb, a lot of obstructive patients respond well to the Atrovent and the duoneb. Helps open the airways, decrease mean airway pressure and peak pressures. And you can actually watch this on some super critical patients where you go in and your peaks and means have increased, you suction, you do your vent check, you come back and you do your breathing treatment, and you can come back a few minutes later and see their mean airway and their peak pressures have come down due to the bronchodilator administration. Pulmonary edema and pneumonia. Pulmonary edema is what happens is due to decreased cardiac output, due to cardiac injury of some sort. This could be cardiomyopathy. I've seen it happen with really bad heart attacks where the heart function just plummets. It causes a buildup of fluid because fluid's not effectively pumping through the kidneys. So that fluid begins to back up and enter into the lungs, leading to increased oxygenation needs. This is due, you will see this as pink frothy secretions, and you can actually see this come up and out of the lungs. It's really freaky, and it's very satisfying to suction. With pulmonary edema, Lasix is your best friend. You want to try to get fluid off this patient and out of the lungs, and high peak pressures in order to help push that fluid out of the lungs and back into the circulature. Pneumonia is consolidations. This is either from secretions or infections in the lung, which inhibits proper lung function. Basically, it's just it's in the lungs, a bunch of shit gets caught. When you have a pneumonia patient, think PEEP and antibiotics. No matter how much you ventilate, no matter how beautifully you manage your ventilator, if you don't get antibiotics on board, you're going to have a hard time managing pneumonia. So how do you ventilate these? Both of them use PEEP. This will help add pressure to open up, to increase oxygenation, and then support the symptoms and normalize your ABG. Pulmonary edema, you have to wait for that fluid to respond. You have to wait for that cardiac function to improve. Pneumonia, you have to wait for the antibiotics to fight that infection. And then do your best just to do proper management. Regulate your ABG, maintain high PEEPs, and get your patient as synchronous with the vent as you can. Okay, burns and inhalation injuries. This is where it's a little bit of a transition, because this both can and is not directly effective in the lungs. So burn and inhalation injuries, either direct or indirect exposure to fire or smoke. This can be externally or via inhalation, depending on what's going on. Identifying features are fast tissue swelling. You can tell by the environment. They'll tell you, if you are getting a burn patient, EMS will call ahead and let you know. First thing you want to do, especially if it's a situation where they might have some black soot around the nose or they suspect burn inhalation injury, is intubate as fast as possible. Because what happens physiologically is, due to that burn, those tissues swell, and you can lose your airway crazy fast if you don't get an airway in there. It's pretty common to potentially get a smaller tube if it's been a little bit in your patient, because of the tissue swelling. SpO2 will read 100, especially if there's inhalation due to carbon monoxide poisoning. So don't trust it. So you're like, okay, so I get a burn patient, what do? We intubate as fast as possible. If there's anything I can tell you about a burn patient that I can drill into your head, is intubate. We want high FiO2s right now, and that's because we don't trust our SpO2 monitor. And we also want to flush all that carbon monoxide and any of those other gases that might be in the lungs or in the circulature out of the body. You will ventilate similar to ARDS, where you will do really high PEEPs, high rates, low tidal volumes. And part of how this goes from being a lung to possibly not a direct lung thing is, if there is a bad burn, they'll do what's called fluid resuscitation. It's common and it's necessary, but the lungs will take a hit. And the theory by that is they're just going to dump as much fluid into this patient as they can, intravenously, in order to have that, the fluid ooze out of those burns and out of the body in order to prevent an infection. Infection is the biggest risk for burn patients, because their skin is compromised, and our skin is what protects us the most from infection. So since we don't have skin, they're just going to pump fluids in order to, while they're doing wound care and caring for these patients' burns, they're going to ooze and get fluid out of the patient so that we can prevent infection. Well, if we have excessive fluid, it's also going to add fluid to the lungs. And that's why we want higher PEEP pressure, higher PEEP settings, and then a low tidal volume and a high rate in order to prevent pulmonary damage. We want to protect the lungs while also being able to help this patient through their burn situation. And yes, I have had a lot of these patients do tend to get trached, and that is part of the tissue swelling because the increased swelling in the upper airways can make it so we can't safely extubate. So quite a few of these patients end up getting trachs, and honestly, as horrible as a trach sounds, on these burn patients, they are a blessing to get a trach. Shut up, Hinge. I'm teaching. Okay. Major surgeries. Most of them will be thoracic or abdominal. You might have some cranial and facial, and then just generals that might not have gone well. Most of the general surgeries will end up getting extubated and being fine and not your problem, but thoracic and abdominal, you will do a lot. First thing I do, this is what I do a lot of at work, are major thoracic surgeries when I work the adult side. I will say with major surgeries, just as with anything, communication is your best friend. So once they bring the patient in, we get the patient settled. I start initially in an assist control setting because they will still be sedated and potentially paralyzed from surgery. You might hear while you're in the room, them say, hey, are we reversed? What they're saying is they're giving a reversal for the paralytic from surgery. After they give a report and we're all settled, I'll just turn to my attending and be like, how aggressive do you want me to be? Do you want me to get this tube out as fast as possible? Do you want me to just chill tonight? What do you want from me? Just chill and do our thing? Do you want me to wake them up and be annoying? And that's how I know how aggressive I need to be with weaning. Another thing is just manage patient vent synchrony. You will make lots of changes, especially if it's a rapid extubation protocol. Because I like to start assist control, and then I'll adjust on my first blood gas. And then once the patient starts waking up, I'll either have them on an SIMV with a very low rate if they're super sleepy, or else I will just switch them over to pressure support and wean their pressure support until we're on minimal. Most of the time, the biggest thing going against you on surgery patients you're trying to extubate as fast as possible is sedation. So you'll try to normalize the ABG. I like a little bit higher, this is just preference, this is not gospel. I like a slightly higher PEEP to begin with to help recruit those lungs so that we oxygenate a little bit better. And then I wean my PEEP once we get closer to extubation. And then adjust your tidal volume as needed for specific surgeries. Some abdominal, they might want a little bit higher tidal volume. Or some thoracic, they might want a little bit lower if they're having blood pressure issues. Trauma. Alright, so I don't know how many of you have been in any traumas yet. This is where I miss you guys. I would rather just talk to you instead of just sit in my hammock and talk to myself. So trauma. This is a fracture, major injury that can either be generalized or specific to areas of the body. What will happen is, if you know a trauma's coming in, everyone will take their respective places. You'll be at the head of the bed, and either they'll already be intubated, depending on what's going on, or you assess for intubation. Take your time. You are airway. Airway is most important, quite honestly. So if they want to start turning and stuff and your tube isn't secured, speak up. I've been in those situations where they're like, okay, we're ready to turn. And I'm like, no, my tube is not secure. We are not moving to assess the back until my tube is secure, and then get it as secure as fast as possible. Because a lot of EMS They do good work, but they don't do good work securing your ET tube, so don't trust it. If I can give you any advice. Then they'll go from head to toe on their assessment to see where the injuries are, what happened, what mechanism, and then think about how these different injuries will affect the pulmonary, cardio and pulmonary system and how it'll affect you. Do we potentially have a pulmonary hemorrhage and you just have blood coming up your ET tube? I've been in those situations. Potential clots if they have large bone fractures, whether it's a full fatty emboli or a blood clot. Flail chest, this will affect ventilation strategies. The ribs they might have to go to the OR to plate those ribs. The best way to manage is to normalize the ABG. Find a balance between having appropriate recruitment of your lungs and pain management. This is a time where I typically will keep my PEEP around 5 or lower, especially if they were previously healthy. And then assess why are we intubated, whether we're headed to surgery, maybe our patient just is not doing well and it's just one less thing to stress about. There's a whole bunch of... There's no cut and dry strategy on how to ventilate a trauma patient because there's no cut and dry trauma. Neurological conditions. This could be a traumatic brain injury. This is why I put it after trauma, because it'll be it's common to have after head traumas. Intracranial bleeding, whether the patient had an aneurysm or stroke. Myasthenia gravis, mind to ground. This is a progressive paralysis from the head down to the ground. Guillain-Barré, ground to brain. Same thing, any type of paralysis, such as anything damage with the spinal cord, and ALS. The majority of the time, lungs will be healthy and easy to ventilate, but watch for fluid imbalance, and sometimes prolonged ventilation can cause some damage. And also, if it is a trauma like a traumatic brain injury, you might have to worry about other things that come along with a trauma. A lot of neurologists, the first 48 hours, like to have lower CO2s. And this isn't like insanely low. We're talking like low 30s. And then after the 48 hours, you return back to normal ventilator management. Their theory is with CO2 is a vasodilator. So they're wanting to decrease CO2 in order to cause vasoconstriction in the brain in order to decrease intracranial pressures. And that's why is they're doing everything they can to decrease intracranial pressures. This includes giving a diuretic that's specific for the brain called mannitol, anything like that to help prevent brain damage by decreasing swelling. Vascular shunting is decreased blood flow to the lungs, leading to decreased oxygenation and increased oxygen needs. That's just the fancy wording for we don't have enough blood flow to the lungs, which makes it hard to oxygenate because we are having a hard time moving the oxygen in our lungs into our bloodstream. A few things that this can happen with is pulmonary hypertension, shock, hemorrhage, and pulmonary emboli. And a big part of vascular shunting is, also medications. Find out what's causing the shunting. Why are we not having blood flow? What's going on? The best thing you can do is fix the underlying problem. You'll want to increase your PEEP, but a lot of times with shunting, that's not going to really help the situation because it's all vasculature. So you're going to treat with what you have. So you can either use Flolan, or inhaled nitric oxide. Most of the time on adults, I have seen Flolan because it's cheaper. Inhaled nitric oxide is FDA certified for neonates, but not for adults. So insurance won't cover it if a patient is put on inhaled nitric oxide. So Flolan is about $55 a syringe. Inhaled nitric oxide's about $1,000 an hour. There's a little bit of a price difference for the same effect. FiO2 100% just to help push through any oxygenation you can to oxygenate the body. And then manage your PEEP appropriately. Again, a PEEP As much as I am a bit of a peep whore, it's not going to make a huge difference. Okay. Last pathology we're going to discuss is pneumothoraxes, hemothoraxes, and pleural effusions. So these occur outside the lung, but in the thoracic cavity. So it's in that little extra area in the pleural space where all this is occurring. These are categorized by what's causing these. So pneumo is air in that pleural space. This is mostly caused from trauma, or if you get too high pressures and your lung pops like a balloon. We've all been there. You guys have yet to be there, but we've all been there. Hemothorax, this also comes from surgery or trauma, where there's excess blood in that pleural cavity. Both pneumo and hemothoraxes are best treated with chest tubes. You might potentially have higher PEEPs in order to just inflate the lungs. But once we start draining, that lung will reinflate and all of your peak pressures and everything will come down. And then pleural effusions is excessive pleural fluid. This mostly happens due to infection risks, and this can be drained due to either a thoracentesis or a chest tube. A thoracentesis is basically they just stick a needle in to drain that fluid one time while a chest tube continuously drains. And slightly increase your PEEP for lung recruitment, but mostly it's just getting that external fluid out of the thoracic cavity. And there's Artie when she got stitches in her paw. She's still a happy girl. If I could give you some final thoughts, are to treat each patient as an individual. You're all doing great. Keep up the good work. Artie's proud of you. I'm so sorry that all this is happening. I miss you guys. Your assignment along with this is... Oh, our secret word is quarantine. That's what we're going to do, is quarantine. You're all doing great. Keep your spirits up. Let me know if you need anything. Wash your hands and do something fun for your own mental health. And I will try to get the rest of our lectures up as soon as possible. So we can just maybe power through and get the rest of the semester done and not drag it out. So you're all wonderful. I'm excited to hear your responses. And have a good one. Bye.